you.
Thank you, Joan, and thanks for such a lovely introduction. And yeah, like I was saying, it is nice to be back home, mainly because my children are down here, but I do miss Ireland a lot, and I would much prefer to be there in person if that was possible. Yes, so I'm going to talk about humanizing birth and some of the things that we've sort of, I guess some of the insights that we've had from the COVID pandemic. And I'm hoping that this is going to at least present something for you to think about. I know you're all experts in your own right, so I'm feeling a little bit like I'm speaking to an audience of the same. But here we go. Anyway, so before I really kick off, this is something that we do in Australia, and I just want to acknowledge that I'm actually on the lands here today of the Kaurna people, and that I would like to also acknowledge the traditional custodians of whatever lands you're all on, because obviously we're all around the world. That we pay respect to our elders, past and present, and know that their knowledge and experience holds the key to the success of future generations. And I guess for me as an Australian midwife, part of that is about, decolonising knowledge and information and birth practice. So I came across this quote actually today while I was just doing some final touches on this presentation. And it was from an article in the Atlanta. And this person was saying to study COVID-19 is not only to study the disease itself as a biological entity. What looks like a single problem is actually all things all at once. So we're actually studying literally everything in society at every scale, from supply chains to individual relationships. And I just really thought that captured what I'm going to talk about today, because really we're looking at all these levels in society. We're looking at the sort of macro ideas and beliefs that we're all situated in. We're looking at policy and practice, the meso level of society, and we're looking at individual experience. And as midwives, that's the most important thing to us, because that's, the experience that women are having in pregnancy, birth, and postnatally. So I thought that was really interesting because, we really are looking at the collapse of the world as we know it. And we've had to have a really rapid response to things. And so even while all of the pandemic was unfolding, and people were grasping to try and get something together and information together. And in the meantime, what happened is it revealed all of these issues that were already there, really. So what I'm going to do is just talk a little bit about the humanization of birth, where it came from, a little bit about my, where my work sort of fits into that whole big project. And then the impact of COVID and some of the things that we can take away from that. So humanization of birth really was first coined in Brazil as a positive language movement to address obstetric violence. And it was positive, it was done particularly so that practitioners, so that we could talk about obstetric violence without sort of putting anybody's noses out of joint, really. And there's still the debate still in the literature there about whether we should call it, what it is, which is obstetric violence, or disrespect and abuse, or should we talk about respectful maternity care, or should we talk about humanization of birth? And there's a real overlap between all of these things and all of these ideas. And authors will talk about why they've decided to use a particular terminology. Then in 1993, which was incidentally, and I've put it on the bottom of the slide, the year that the UN declared the elimination of violence against women. These weren't related, but I think, in terms of socially where we were at the time, this organization in Brazil was really at the forefront of this movement. And really to think that we're only just talking about violence against women from a UN point of view in 1993. So what the Network for Humanization of Birth, the Rehuna, if anyone knows how to pronounce that better than me, please let me know. But what they did is basically an activist group, collection and dissemination of knowledge, guidance for people who were trying to change things in Brazil, workshops on humanization of birth, and then the first international conference, which many of you will know of this because it was written up in various articles by like Marston Wagner and Leslie Page, who attended the first international conference in the year 2000. So really, it's probably been the last 10 years that it's really kind of exploded. So they were also instrumental in organising policy and practice guidelines throughout South America. And the website is there for those of you that want to follow up on that. So humanization, that was the sort of the beginnings of it. It's now a sort of whole movement, as it were. Like I said, it's sort of really taken force in the last decade and situated within an agenda of human rights and also ethics. And there's probably more, you can probably find more literature on the human rights side of it than on the ethics, but you know, they kind of fit together. So humanized birth, as well as incorporating, you know, this idea of respectful care, is also about really looking at medicalization and industrialization of birth practices. So it's more than just refraining from violence and being polite and caring in your relationship. It's actually about dismantling structures. So then Venezuela defined the concept of obstetric violence in 2007 in their legislation for the right of women to a life free of violence. And obstetric violence was identified as one of 19 forms of violence against women. And I think it's important here to just really kind of clarify that this is a gendered issue. And it is because, you know, women, other than the birthing people, the odd person who doesn't identify as a woman, this is essentially a historically structured, you know, long-term violence. So the way that it was described, though, in this legislation, and I've got the quote there, and this is from Sadler's paper, and the appropriation of women's body and reproductive processes by health personnel, which is expressed by dehumanizing treatment and abusive medicalization and pathologization of natural processes. And I just really want to kind of draw your attention to that, because I think this is an important thing that we really need to consider as we go through these ideas about what COVID has taught us, that we need to focus on demedicalization of birth and the normality of normal birth. Because when we don't, it results in loss of autonomy and the ability to make decisions about bodies. So then this is kind of a bit of a sort of step by step, the literature, you know, the primary literature, there is quite a lot of it now. So in 2010, Bowser and Hill for USAID did a landscape analysis where they categorized disrespect and abuse. And again, you'll see this change of language. So obstetric violence, disrespect and abuse are kind of interchangeable in the literature in a way. And they determined these categories as physical abuse, non-consented care, non-confidential care, non-dignified care, discrimination, abandonment of care, and detention in facilities. And that was mainly around for non-payment in countries where women had to pay for healthcare. So in response to those categories, the White Ribbon Alliance in 2011 sort of formed these corresponding rights for women. So the 7 rights of childbearing women in response to these categories of disrespect and abuse. And they documented rights as being freedom from harm and ill treatment, the right to information, informed consent and refusal, choice and preference, confidentiality and privacy, dignity and respect, equality, freedom from discrimination, the right to timely healthcare and the highest attainable level. So then, you need to be looking at access there, and liberty, autonomy, self-determination. So you start to see the language that comes through in the responses to obstetric violence and disrespect and abuse. And there are echoes of it throughout the next few pieces of literature that I'm going to show you. And I think it's clear from seeing these responses that it starts to address these structural issues. So freedom from discrimination, autonomy, self-determination are all about much more than just the individual relationship that happens in the room with the woman. So in 2014, in order to address this increasing understanding of what was going on, the WHO put out a statement for the prevention and elimination of disrespect and abuse. And this is mainly facility-based childbirth. So they advocated for more research and action on disrespect and abuse, and that governments should support this. That programs that support quality maternal care and respectful care should be emphasised. That the rights of women should be emphasised. That that we need to find out how we can maintain, develop and maintain respectful care practices, and and that in order to do all this, we need to involve all stakeholders, including women, in efforts to improve quality of care. So this was a kind of, they sort of stepped back and tried to see how we were going to address this issue, and from a country point of view, how they could take that on themselves. And what followed from that was Megan Bowen and colleagues categorized mistreatment during labour and birth in a systematic review, and they categorized it in you can see on the left-hand column is the sort of the third order theme. So the main categories are on the left, and then the behaviors are on the right. And what they found was physical abuse, sexual abuse, verbal abuse, stigma and discrimination, failure to meet professional standards of care, poor rapport between women and providers, and health system conditions and constraints. And a lot of the literature talks about how we need to support health workers in these systems that are based on structural problems that, like gender bias, discrimination, colonization, racism. How do we actually support people in those systems to provide respectful care, rather than kind of blaming them for it, I guess. So that's an important thing to consider. Then from that, or not, not from that exactly, but the next sort of piece of evidence that we have around this is a qualitative evidence synthesis, which looks at domains of respectful care. And again, you'll see the language coming through about respect, dignity, and so on. So freedom from harm, maintaining privacy, preserving dignity, providing information and getting informed consent, ensuring supports are available and accessible, the quality of the physical environment and the resources, providing equitable care, engaging with effective communication, respecting women's choices, and strengthening their capabilities to give birth, and the availability of competent and motivated human resources. And this is where, another issue is the under-resourced healthcare systems, and where staff are stressed, not supported, overworked, underpaid, often women, mostly in maternity care, is not the best starting point. So, really working there is important. And so that they can then provide efficient and effective care, and continuity of care comes in there as well. And you can see here that I've just highlighted where we are seeing breaks in this respectful care because of COVID. I mean, probably all of them actually, but I just highlighted a few as I was putting the slides together, because you can see that, there was a real breakdown in terms of what constituted respectful maternity care and what happened during particularly the first few months of the pandemic. And then I think people kind of gathered themselves together a bit. And then in 2019, Lalonde and colleagues put out 12 steps to safe and respectful mother-baby maternity care. And you can see as well this kind of the same language here: provide respect and dignity, informed choice, free or affordable care. So that's right up as the number 2 there. And I think that's really important in terms of access. Providing mother, baby, family, maternity care, which is the philosophy of care that is put forward by these authors, and which is, a sort of holistic midwifery, includes midwifery philosophy of birth. Offer continuous support, provide pain relief measures, including non-pharmacological, provide evidence-based practice. And I think that's one that we need to focus on as we move forward, and that will become clear as I go on. Avoiding harm, enhancing wellness, providing emergency care and transport. And that was another reason why women were denied choices during COVID, because of the transport and emergency. They didn't want to be diverted from that for home birth, in the UK at least. Have a supportive HR policy, care continuum, breastfeeding and skin to skin contact. So you can kind of see, that was just a kind of quick snapshot of the development of humanized birth. And then we, as you would all know this, the recommendations for a positive childbirth experience, the World Health Organization 2018, includes respectful labour and childbirth care at the top. And a lot of those things are sort of pulled into that. So having choice, continuity of care, effective communication are all part of that as well. So that's kind of where we are in the literature and that landscape. I guess the other thing that I wanted to say here is that dehumanized childbirth practices occur globally. A lot of the literature focuses at the moment on low and middle income countries, partly because I think the lack of resources in those places make it more evident, or at least there's probably a few reasons for that. But the point is that the Lancet series in midwifery that identified that the too little, too late, the lack of resources and access to quality care, and too much, too soon, medicalization, over intervention, and iatrogenic harm does occur globally. It's a global problem. It happens in high income countries, it happens in low and middle income countries, and it's not a matter of either or. So too much too soon happens frequently in low and middle income countries as well as high income countries. Although those in high income countries have got less chance potentially of having the too little too late because healthcare systems are more robust and the resources are there, but yet there's still discrepancy within countries. So for example, in Australia, Indigenous women have got a much higher mortality rate, stillbirth rate, adverse outcomes all over are higher for Aboriginal women in Australia, and similarly, you see increased mortality with the Black women in America, and I think in the UK as well. So, it's important, but it's important to realise that it can both happen in both countries, and too much too soon frequently happens in low and middle income countries when the sort of Western model of birth has been imported with no infrastructure to support it. So humanized birth really counteracts those problems that were identified in the Lancet series of too little, too late, and too much, too soon. And what it focuses on is the individual woman or birthing person respecting their experience, needs, desires, individualized care, commitment to address the social determinants of health. And that means really having a focus on those problems of poverty, racism, colonization, fragile states. And, I know that's easy enough for me to say here from my very comfortable chair in South Australia, but I guess I'm just saying an awareness of these is really important to keep it going, and supporting each other where we can from a global point of view and a country point of view. And scaling up midwifery is vital to humanized birth. It's, it is the answer and the solution, and this is what has to happen.
J'ai reçu, attends. Moi, j'ai reçu que ce matin.
Sorry, I will try to mute him.
That's okay.
Sorry. Now
so we could have a little discussion.
Yeah.
But my French isn't very good.
You can keep him. I've muted him.
Yeah. So some of what I'm going to share next is, like Joan said, I did sort of, this book came out of my PhD research, which was actually looking at epidural use and hospital birth culture. So it's really looking at the mechanism of effect of too much too soon, or at least how we can understand it, because I think we can oversimplify it sometimes. So that book, you can get that if you want, the links there. I also curated a series of articles based on those concepts, but I sort of expanded it a bit and wrote it with some colleagues, including Inga was on one of those. And they've put that together in a little ebook thing that you can go and buy. So yes, anyway, that's where you can find some of this stuff. But yes, so really I didn't really set out to look at humanization of birth, but what I found was one of the ways that we can start looking at it and addressing it. So mechanisms of too much too soon include some of the really underpinning beliefs of society, and these were very obvious once I got into the hospital labour ward, a hospital labour ward. So techno-rationalism is one of these big beliefs. And what techno-rationalism does, and it really underpins a lot of the way we think in sort of currently as a society or as a global society. And what it does is it equates scientific advances with progress. So any discovery is associated with progress, as if we're on this kind of straight line from ignorance to knowledge, which of course isn't the case. It also then aligns progress as a moral good. So there's no kind of, if you want to step out of that frame of thinking, then you kind of at risk of being labeled, troublemaker or antiquated or, one of those other sort of labels. And certainly that was the case in terms of talking about physiological labor without using analgesia, which is kind of what I was looking at when this developed. Technological imperative means because the technology is there, we should use it. And that's really clearly throughout a lot of Western medicine. But the example that I go to all the time is CTG use. We know that it doesn't do anything. We know that it doesn't improve outcomes. And yet it's used all the time because it's there. And if we don't use it, somebody might come back to us and say, well, the technology is there, why didn't you use it? So it's kind of like this implied effectiveness, which I've actually got down there. I'm going out of order now, but this sense that because it is mechanical, because it can do a printout of things, then obviously it's going to be more effective than a midwife sitting in the room with a woman listening into the fetal heart. Of course, what we know is that the midwife sitting in the room is much more effective than the technology. But that's not, it's not given any kind of estimation in terms of medicalized care perspective. So midwives can be out of the room looking at their CTG machine and, the woman's kind of deteriorating over there and you don't actually see it. And not to mention the fact that the relationship is a protective factor and saves lives, so that the midwife-woman relationship is taken out of all of this. Other things that it does, emphasizes pain avoidance. It looks at abstract risk rather than specific danger, and it esteems complex over the mundane. So again, this is the technology over the midwifery practitioner, which is seen as more effective. So other mechanisms of too much too soon is medical dominance, and I know that many of you will be familiar with these ideas. So medical dominance is reductionist. So what we see in the refusal to take any other perspective other than its own, the medical model of childbirth will go straight to the uterus. So it sees just the uterus in the bed, or the the broken leg over there, or the whatever the thing is. And it's also mechanistic. So when we see the uterus there that isn't meeting the time requirements, which we now know because of recent research into lengths of labor, we've been doing completely wrong anyway. I mean, any midwife could have told you that, but we have the research now to show that, the decades of 1 centimeter per hour measurement is completely flawed, and there's absolutely no reason to monitor a labor in that way. But what we've done is we've monitored the labor in that way, and what we do then is medicine, I say we, what has been done is that then you target the uterus. So if a woman stops laboring, even though we know all of the information about hormones and the things that stop women from laboring, we know about oxytocin, we know about adrenaline, we'll go in and put up the syntocin on without actually looking at the whole picture and what's happening for that woman, what's happening in her environment that might have slowed the labor down. It's also gendered. So medicalized childbirth models are based on scientific knowledge that for at least 2 centuries saw women's bodies as flawed, as risky, and or as invisible. So there's a great book actually that got written, it came out last year, I think, about data and how much of healthcare data is research done on men's bodies. I should know the name of it, but I can't remember. But you know, women were not researched, men were researched, and then somehow that was supposed to apply to women. And in addition, doctors were kind of positioned as rescuers of women in terms of childbirth. So not only did they rescue women from pain and distress and all of those things that they thought women couldn't cope with, but they also negotiated directly with the fetus. So the baby became the kind of, you know, the baby was the patient, as it were, and the doctors could rescue the baby from this, what was seen as a very dangerous process. And one medical textbook from, I can't remember, I'd have to look back through my own writing, but, you know, equated labor in terms of danger for the baby as like falling on a pitchfork. So, you know, it was seen as a very dangerous thing to do. And these are all sitting just under the surface of what we do now in modern times. And the other thing that really is underpinning it is obstetric risk discourse. Now, there's this whole other risk discourse socially that those of you that have read Ulrich Beck will know about, but I'm not going to go into that side of it. But just simply looking at obstetric risk and how risk is perceived it really affects the way that things happen. So for a start, even though risk is about populations, and you can never categorize risk individually. So you can never say to the woman sitting in front of you, yes, 1 in 10,000 women this happens to, and you're going to be the one, or you're not going to be the one. You know, this is the crystal ball that we all wish we could have, but you can't. So it's true that even if we know that it's 1 in 100,000, we cannot predict anything. And yet medicalized birth models will make blanket policies that encourage over-medicalization to prevent one adverse outcome, which means then that women cannot decide what they want to do. If every woman has to be induced at 40 weeks or now 39 weeks, thanks to, you know, some recent research. I won't go into that. So you can see how straight away this takes women's autonomy away over their own bodies. Focus on technology over human interaction. It's practitioner-centered. So, and it always has been. It's right from when obstetrics first started. You know, the positioning of women on their backs in their beds was so that the practitioner could more easily grasp the baby. It had nothing to do with the woman. It also reproduces power relationships in society. It's not evidence-based. And I think this is a really important one to keep hold of, because it's this kind of comes across as if it's effective and evidence-based all the time in its own discourse about itself. And yet it really isn't, as you all know. And the example again of the CTGs. It may therefore lead to decreased safety. So obstetric risk discourse can put women at risk just simply by the fact of how it operates. partly because it's blind to the risks that it itself introduces. So iatrogenic risk, risk of cesarean sections, risk of, all of those things that happen in obstetric models is not seen as risky. And this is what I found in my own research. And this was one of the findings, was this sort of institutional paradox whereby intervention was normalized. So induction, for example, was not seen. There was an instance where an induction had been planned. It had been, between the conversations and the practitioners and all the notes, it was discovered that this woman actually didn't need to be induced for whatever reason. They had decided to induce her, and they just went, oh, well, we'll just carry on with it anyway, because the ball's in motion. If we explain to her that she doesn't need it now, then she'll lose faith in, her care. And so during all of that conversation, the potential risks of induction were not discussed at all. And on the flip side of that is the unpredictability of normal physiology came with a discourse of risk. So anything that tried to give women more time, or midwives who were trying to implement practices that supported physiology, were seen as risky. And then with the institutional momentum, so there was this kind of speed within the system that said, okay, if we keep women in and move them through and get them out, that's how we're going to keep them safe. And that included avoiding the hospital getting bed block, but it was also about getting the baby out. Once we've got the baby out, then it's finished, we can move her on, but that next one. And there was this kind of movement like that actually introduced risk to the women. And any kind of trying to go against that or resist that at all, including midwifery practices that supported physiology, were treated as risky, even though essentially they saw midwives as being in charge of the normal, and they'd be this kind of, we'll go and get that baby out, what's right, the low risk women, the midwife will go in and that will all be fine. But the minute they tried to actually do something to support physiology, if those very narrow parameters didn't occur, then immediately her practice would be in question, her philosophy would be in question, midwifery would be in question. So these are really sort of complex things to try and tease out in practice. The other part of that study, that part of the study anyway, was again the significance of the midwife in practice. And that bluey purpley bit represents the woman, and the green and dark green is the midwife. And there's this kind of relationship between them represented by the arrow. And even these women had not met these midwives. They didn't know them at all. And yet there was a sense that they formed a connection or didn't. And the significance of the midwife in that room and her beliefs and what she did actually have the most impact on the woman's experience of birth and potentially the outcome. Certainly it affected whether or not that woman had an epidural in many ways. And what the other part of that is the idea of tailored information and care. So women are bombarded by all sorts of information from friends and family, social media, the media, birth books. And what they wanted was somebody to guide them on the day. I don't know if I'm going to need this. I don't know if I'm going to need that. I don't know what's going to happen in my labor. It's completely unknown. What I want to do is trust that the midwife that I have is going to tell me bit by bit and step by step as I need to know it, not throw it at me all at once or not tell me, or withhold information. So it's really key that we focus on scaling up midwifery and the relationship and what that does. So this is a chart that we put together, Leslie Page and I, when we this is one of the papers from the practicing midwife, and we adapted it from something that she'd done before about the characteristics of humanized birth. And really, you know, we did sort of frame it as a demedicalization of birth, deindustrialization, a decolonization, because so many of those things that have gone into the last few hundred years of birth need to be de-implemented. So much of what's in that chart I've just talked about. So I won't sort of say that out loud now, but you can go back to that. So I guess while it's important to look at disrespect and abuse, and you know, how we measure it, how we challenge it, what kind of interventions do we do at the individual level, it's really important to keep hold of those structural issues as we go forward. Socioeconomic, institutional, gendered, you know, bias, prejudice, all of those things. And as we go. Sorry, I've just lost my train of thought then. So COVID-19, what happened when the pandemic hit is it just pulled down any kind of veils that we might have had over our eyes, that, you know, we live in a society that is just and equal. Even the effects of lockdown, so the living circumstances of people. You know, if you live in a 1-bedroom flat with 5 kids, then you are not going to have the same experience of lockdown as if you live in a house with a garden with your partner. You know, it just revealed all of these things. Poverty, domestic violence, access to green areas, all became very stark. The fact that Black and other minorities have a higher mortality rate in Western countries, you know, in countries where that's a factor. Obviously, the effect on pregnant women and birthing people, which is what we're talking about today, and also the vicarious trauma on staff, midwives and doctors. And I'm not going to talk about that either, but that's certainly something that needs to be in effect. And there are a few papers on that as well. So what happened during COVID is that women were denied a companion in labour. They were required to have interventions. For example, epidurals were being recommended to women, or not even, it was stronger than recommendation. Forced induction and cesarean section without medical reason. Women were being separated from infants, discouraged from breastfeeding, denied access to water for labour, or indeed denied access to services completely. Closing of home birth and community birth, and women were told to give birth in hospital, which of course they were loath to do because they were worried that they were going to contract COVID. And this, you know, kind of reflects the home birth argument that happened before the pandemic came, only it's sort of, again, it's much more magnified. Redeployment of staff to other areas, removal of services, and increased mortality because of this is what one of those authors is saying, Jolivet, that because of all of these things happened, women actually died more than they would have. And I'm hoping this is going to work. Excuse me. Because Open Democracy have done a, hang on, I just have to move all your faces. Have done a website here of incidents where services were denied or who guidance was breached. So the World Health Organization did very quickly come up with guidance around these issues, which is really good. And I think that's what's going to...
Sorry, Liz, you may have to stop sharing your screen and sharing the other one to open it. Otherwise,
is it not working?
No, but
Oh,
if you
all
stop
right.
if you stop sharing your screen now and
Yeah.
choose the other one that you have opened, it's supposed to work.
Okay. I'm worried that that's going to do
It-
something. I will leave it there for you to all look
okay,
at. The point
okay.
is, I think that it's happening all over the world. And even so, there's not many there. It feels like there would be much more than that happening. So, and this was the Jolivet paper has explained how rights have been eroded. So, lack of personal protective equipment, personnel diverted, maternity units converted into COVID-19. So you can see that maternity as a sector of healthcare, it just lost its it sort of just went right down the ladder of importance. And fair enough, there was a pandemic happening and people were panicking, but it just really does illustrate where things were and where things are in terms of women's health. What else did I want to focus on here? Yeah, things like mandatory separations, forcing women to have cesareans and inductions. Most of these did not have any evidence behind them at all. So I thought this was a beautiful quote, which just goes back to what I was saying about sort of medicalized birth models. But what they were saying during the pandemic was, in the absence of clear, consistent, coordinated guidance, measures are implemented based on fear instead of evidence and rights. And I think that's what we need to take with us into the future in terms of solutions. So what did we learn from COVID then? Opportunities to improve. And this is always, we always look for opportunities, don't we? So I think keep addressing the structural issues, and it's got to be a human rights focus. We need to increase efforts to demedicalize birth, and I think that is a priority. We need to keep normal birth out of hospital, and the efforts to do that, I think we need to double down on those efforts. Focus on an evidence base for practice implementation, because the evidence is there now and it's coming all the time. And so keeping a focus on evidence should be there, but it should never trump the human rights focus. So evidence is about guiding decisions, not about forcing people into them. Prioritizing maternity care. So maternity care went right down, as we saw, in terms of prioritizing, and it impacted on maternal health worldwide. In order to prioritize maternity care, we need to scale up midwifery. We need to support midwives. We need to pay them properly. We need to give them equipment. We need to liaise really well with obstetric services and build healthy relationships there. We need to care for the midwives that are caring for the women. And I think planning for future events. And look, I mean, I am not the expert here in terms of what we need to do if we have another pandemic. I think we have learnt from this. I think World Health Organization, did come together. Colleges, professional colleges and disciplines came together, and there's a lot of information out there now about what you can and can't do, what isn't recommended, what will and won't have an effect, whether things are vertically transmitted, that women and babies should stay together. And I think we've learnt from this. The whole world's learnt from this experience. But planning for future events, I think it's important to keep a focus on, as I said, human rights above all else. And this was just a paper I found because it helps to talk to governments. If you've got money, talk as well. So this was a study that had been done during COVID. They modeled a whole population data set and just showed that if all low-risk women gave birth at home during 2017, which is when they had the data for, cesarean section rates would have reduced from 13.4 to 2.7%. 860 fewer inpatient bed days, and 10.1 fewer hours of intensive care unit. This is purely from maternal point of view, not to do with COVID, but they were making the point that in a pandemic, you need to be taking women out of hospitals, not making them go into them, where they're going to have cesarean sections, block the beds and use up intensive care beds. And it makes me laugh, because what Leslie Page and I came to in one of these, this paper, I think, that we wrote for the TPM, was that really humanization of childbirth comes back to love and humanity, and really that's the essence of it. And we said in that paper that, and Leslie had made this point somewhere else, that humanization of birth is as crucial to the human race as climate change, provided we all survive climate change. It's part of the same crisis. So we are reliant on these outdated beliefs and ideas and models, social structural models and beliefs, that really, we think that we can interfere with physiology and ecology without making any difference. These are the belief systems. We're now learning that we can't. The belief that we're all self-reliant individuals, that we're not intrinsically connected to each other, that we don't require fundamental social support and community, that we've allowed commercial interests to dominate. And I'm saying this as a human race, and some have been, obviously these have been pushed by some people more than others. We have no idea of the consequences of disturbing birth to the extent that we have on future generations. So, it's absolutely critical that we address this issue. And we are starting to get a bit of evidence now. And that's all I've got to say about that. I've got some references there for you all. And yes, thank you very much for having me.
Liz, that's fantastic. Thanks a million. And if it's okay with you, I'd love to open the floor to questions. I'm not sure if you want to use the hand function for that. Certainly don't worry, Liz, there will be lots of questions, because I think I already have a foolscap page already written down. It's just so stimulating and amazing. I suppose one of the things that really comes through is this sort of fetocentric approach, even in countries where there isn't a law to say, as we did have in Ireland, that the right to life of the fetus is equal to that of the mothers. The fetocentric approach still seems to dominate, even without a sort of a legal reason for it, if that makes any sense. I know one of the things, and I don't know, in our last meeting, Liz, it might be useful to note that we had as a group a discussion around COVID-19, and the network all contributed to the types of changes that were happening in practice in their country. And certainly companionship was a very big thing that I think we're probably going to see some of the consequences of. But what I might do is just see if there are any questions. Would anyone like to put their hand up? Otherwise, you know me, I'm very happy to start. I always like to be more informed than I already am. One of the things, Liz, I was wondering about, while people maybe get a chance to think about something, is we've actually got something that's happening in Dublin now, which is a study that's being offered to women for an induction of labour at 39 weeks.
Yeah.
Routinely. You may have heard about this.
Yes, I have.
But there's a big issue with not only the offering of it and the way that it's being offered, in terms of, here you are again about this techno-rationalization and somehow that it might be good, but it's the issue of offering it in a pandemic when women will be potentially labouring at home and may not actually be able to get to hospital. And I know one of our colleagues from Turkey mentioned in our last meeting that they had an increase in out-of-birth hospital numbers because women were afraid to go because of the lack of companionship. And I'm wondering if you've any experience of that, Liz, women changing the way they would normally behave because of the restrictions.
Yes, I think, well, it certainly happened here. And, you know, the demand for independent midwives went up and through the roof, actually. And of course, the midwives aren't there to support them because, sorry, I'm looking at the chats at the same time.
Yeah.
So, yeah, absolutely. And I think women were rightly not wanting to come into hospital during a pandemic of such proportions, where going into hospital was going to put them and their baby at risk. And by the same token, there were also services that were being pulled away from women. So, you know, there were less visits. There was implementation of telehealth, which is a much different sort of situation. And antenatal classes actually was one of the things that really got, it disappeared here. I don't know what it's been like everywhere, obviously, but they just stopped having antenatal classes, and it took a long time before anything really came online. And the problem is that some hospitals, I think, are going to just abandon them altogether now. That's what I'm hearing. Other things that happened over here were, the water birth was out the window, and epidurals were being recommended to all women. I'm just going back to that point about induction. I think the increasing induction rates, I think, are really one of the things that we need to focus on, you know, as researchers and as midwives, because it's just endemic, and we don't really have good evidence about what syntocinon does long term, and we don't have good information. And that study that I think the rotunda that I think the you know, the study that is I was looking at that study, and it's not even it's looking at home versus hospital induction, and I'm not sure why they've decided that 39 weeks is a good idea, other than it's based on the ARRIVE trial, which you could really pick holes in. For a start, most of the women they approached didn't sign up to the trial at all. So what is that saying about what women think about induction of labor? So yeah, so I'm just seeing there that so from the chats there.
And
I don't know if I didn't really answer your question.
No, there's not an answer. It's really, Susan Garcia has a question.
Yeah, that's right. Thanks so much, Elizabeth, for this very interesting talk, and also for setting the focus on this important topic of violence and obstetric violence and human rights and women. I was just also wondering, thinking about medical interventions, could it not also sometimes be a human rights violation not to intervene? Especially, yes. You were talking about the pain relief, and I'm thinking women, like it sounded like it was a problem in it by itself to give epidural, for example. And I was wondering, maybe looking at it from both sides, even interventions can be an act of human, to provide human rights and to actually have a humanized way of providing care to the woman.
Yeah, absolutely. And that's a really good question. And it is, you know, all through the literature, it is about access to any kind of technology that women should need or want should be there. So obviously denying any kind of needed intervention goes against that human rights. And in one of the papers, provision of pain relief was one of the, you know, one of those 12, I think it was in the 12 sort of points about respectful care. And when I talk about pain relief, the giving or the not giving of pain relief, what I am referring to mostly is the way that systems are set up. So absolutely, we shouldn't say no to a woman who wants an epidural in labour. You know, that is not what I'm talking about at all. But the issue is that women often don't know what they're signing up for. They're not informed of all of the risk factors associated with epidural, and that's partly because of the thing that I described earlier about it's not really seen as a risk because it's a medical intervention. So it's seen as very safe, which in some ways
also,
it is.
if I may say something, it may also be a risk to be exposed to really major pain. It's, I mean, we are also in the cost action of traumatic birth because, just sorry to interrupt, but I mean, if you are exposed to really unmeasurable pain, that can even lead to developing PTSD. So, I mean, we have to have many thoughts in our head at the same time.
We do, we absolutely do. And I think, though, the system is set up to, and look, I mean, it's different everywhere. It really is different everywhere. And the position that I'm coming from is that it's much easier for women to access that than it is to access someone that is going to support their physiology in a way that can lead to an empowered birth process. Now, there's a whole nother conversation here about pain and how we see pain and the demand for pain relief coming partly when the pharmacology was invented, but also when women were starting to be put in hospital rooms on their backs with no support. The midwives were being taken away, the support people were being taken away, women were being taken out of their communities. They couldn't stand up, they couldn't access heat and movement, and demands for pain relief started going up, pharmacological pain relief. What my concern, more than whether or not, more than whether or not women should have it or not, I'm not worried about that so much. I'm more worried about the fact that I think women should, of course, have access to it. And I agree, it's catastrophic pain is definitely a cause of trauma. But I think we need to look at the systems that skew the physiology of birth that is set up to create a hormonal response to pain that women can cope with when they feel supported, when they've got mechanisms to cope with it, such as water and movement. And the hormonal cascade that follows is one of euphoria, joy, ecstasy, bonding. And those are the things that we're not talking to women about and we're not telling them. So I just think there's a bigger conversation to be had. I absolutely am not thinking for a second that women should be denied access to epidurals, but they should know what they're getting, and some women don't even know that they may end up with a catheter, that they're more likely to have an instrumental birth, and what are the side effects of that and the pain associated with ongoing pain. Labor is, anyway, I won't keep carrying on about that because it is a big passion of mine. But yeah, I agree with you, Susan. Thanks for raising it. Yeah,
thanks very much.
So Liz, I think we've one other question in the time. Myrto has had her hand up. Myrto, if that's okay with you.
Yes, hello, yes. Myrto Kronaki from Greece. I'm an architect who has a PhD on spaces of birth. I've been reading lots of your articles, the ones I could find anyway. And lots of Davis Floyd's book, the classical one. And of course, all of Michelle Dunn's. I wanted to ask you, or it's more like a statement actually, whether you see similarities between the way birth care has been managed the last 100 years or so and the COVID-19 so-called pandemic regarding scientific evidence and how it was utilized or accepted as scientific. For example, the last bulletin of the World Health Organization adopted Johnny Ioannidis' statement research that the death rate among the whole population is the area of 0.15. So you cannot call that a pandemic by the classical definition, but the definition has changed in 2008. So I think there's been a need sort of deconstruct the dominant narrative, just as in birth, because we've been believing in so-called science, or accepting it as the ultimate truth, and accepting cesareans and induction and hospital-based birth. I think it's a similar kind of thing is happening today, disregarding science, what's the word? Scientific evidence, physiological mechanisms, the ecology of our organisms together with nature, so viruses and bacteria and all that. I think it's more or less the same thing, and people are just as uncritical about this as again. It's frightening in a way, and it's used to, just like the witch hunt of the 14th century, or late, it was the 16th century, 17th, anyway, 17th. It's used or utilized to bring a whole societal change. And then it was the first scientific, industrial revolution, more or less, the change of paradigm to sort of scientific paradigm of the times. And now it's the fourth technological revolution, like, you know, what they're doing now, telecommunications, e-life, a virtual life, virtual communication, virtual birth, virtual sexual relationships. So I think it's frightening in a way if we don't acknowledge that there is a cultural shift.
Thanks, Myrto. Thank you.
Thanks, Myrto. Yeah, I agree. And that's why we need good critical researchers to, you know, unpack some of that stuff.
As we all benefit from the technology of Zoom today.
Yes, and I mean, look, and this is not a blanket criticism of technology either. Like they're very nuanced kind of positions.
And as you say, the human factor is so critical in terms of even how we communicate with each other as professionals working together, never mind with those that we're caring for. That human communication is so critically important, isn't it? It's how we do it, and what we say and how we interpret is so incredibly important. Liz, can I take the opportunity to thank you so much on behalf of the network? It has just been fantastic to hear from you today and to challenge us in what may have been our preconceived positions. There's nothing better than a network to open our mind to other ways of thinking and other ways of working and climbing out of our comfort zones, you know, whether we like it or not. So can I give you a sort of a virtual clap, because we can't
Thanks, Jo.
we can't give you
the
real one. And so I would just like to say again to thank you so much. It's been phenomenal, and we're aware of the time difference and everything. So thanks a million, Liz, and thanks for allowing us to record and share this with anyone who couldn't be here today. And so just to say,
thanks for having me.
Not at all, it's been fantastic. So just to say to everybody else that you all have your links for the meetings. I know we've gone over time today, but it was just great to have Liz, and I think we've made the most of every minute that we've had with her. And so we'll see you all in your groups then at what is, I think, 10:30 CET.
Joan, before we leave, the link isn't there for work group 4.
Okay, I will make sure that with Stefan, we will do that now, and I will get that to you to circulate to your group, John, but thanks for letting me know. We'll sort that out.
Okay, thank you very much.
Joan, just to clarify, on the program we got, it says 10:30 until 11 break, and then start in working groups at 11. Is there maybe
perfect. Whatever's on,
yes.
I need coffee.
Whatever's on the time, take your coffee.
And remember everyone that you have to leave this meeting and go into the agenda again and into your groups.
Yeah,
they're very important. Okay.
So in other words, we're all starting at 11. Is that correct? All the working groups?
11 CET.
CET.
Right? Yeah, it's 10 GMT. Sorry.